Our guest speaker today is Dr. Jessie Berry, who is fantastic and so fun to listen to. She hails from California, and we're so grateful to have you here, Dr. Berry. Just a special thank you as we get started to our sponsor for the webinar series, Castle Biosciences, who has helped to make this possible. So with that, I'm going to go ahead and turn the time over to Dr. Jessie Berry.
Thank you so much. It's such an honor to be here. And to those who are joining in or watching later, unfortunately, I'm the tiniest bit sick. So if I cough or need to stop to take a quick break for my throat, please stick with me. So I'm going to do the first part of this exciting webinar today, talking about the navigating a uveal melanoma diagnosis and a little bit about the roadmap from the eye cancer or the ocular oncologist side. I do have some research funding, and I am going to talk today about some trials as well as some companies that are in the ocular oncology space. I actually don't have relationships with any of them. I'm just sharing information. So if you're here, you likely already know this, but uveal melanoma has a whole spectrum of disease. And so you hear a lot of terms thrown around with it, including even ocular melanoma, which really includes melanoma all throughout the eye or ocular space. But when we talk about uveal melanoma, we're really talking about melanoma that's involving the iris, the ciliary body, which is the structure that produces fluid for the eye, that hides behind the iris. And then the pigmented layer under the retina is called the choroid. And we see a lot of tumors forming there as well. So these are the structures that we're talking about when we talk about a diagnosis of uveal melanoma. And uveal melanoma actually is a minimal contributor to the total amount of melanoma that we see. Most, of course, are cutaneous or on the skin, but it does account for about 5% of melanomas in the United States. It is the most common primary intraocular tumor in adults, and primary means it started in the eye. It didn't come from other parts of the body. There are about 6 cases per million, which is about 2,000 in the US. And so that means that this is a rare disease. And so anything that is rare means that there are fewer specialists that treat this disease. I love seeing a cure in sight, and other groups come together to provide support for patients and resources, and for all of you showing up and spreading the word, because again, this is a less common diagnosis and disease. And so when we think about people who are at risk for melanoma, we often have this very stereotypical picture in our head of somebody who's maybe older than 50 years. Men and women are equally affected, but we think about people who have light hair, light eyes, and oftentimes we think about sun exposure, although that's actually very argued. But these are the risk factors we think about when we're talking about melanomas in general. By the way, sun is not argued for skin. But who's really at risk for melanoma? Well, everyone. So in my practice in Los Angeles, I have seen people under the age of 18, so children diagnosed with melanoma, although that's exceedingly rare, very old people, every age in between. If you are an adult in your 20s, it does not mean that you cannot get melanoma. Unfortunately, I've treated many of them. And if you are not light hair, light eyes, it does also not mean that you cannot get melanoma. Unfortunately, while the risk may be different, the risk still exists for all people. And so because of that, you see a lot of episodes through this podcast, but we do recommend a dilated yearly eye exam to check for these things. And the reason we recommend a dilated yearly exam is that melanoma is really a clinical diagnosis. So what does that mean? Doctors understand what that means, but what does that mean for a patient? Well, for a patient, it means that you need a doctor to look in the eye and do some imaging in the eye for us to be able to diagnose melanoma. And by and large, we are about 99% accurate in diagnosing melanoma based on these features when we decide that something has progressed to melanoma. And I'll talk about that as well. So this clinical diagnosis for ocular melanoma being so high is in comparison to cutaneous melanoma, where the biopsy positive rate for something that's possible melanoma is only 10%. But that doesn't mean that ophthalmologists are better clinicians than dermatologists. I wouldn't say such a thing, but rather that the threshold to biopsy a skin lesion is very low. You can take the whole thing off. And get a diagnosis that way. Now, there are several predisposing conditions for melanoma. There are some predisposing conditions that can lead to melanoma, and this includes nevi, and I'm going to talk about that a little bit later, melanocytomas, which are sort of an aggressive looking nevus or mole in the eye, but actually have a lower risk overall of malignant transformation. And then something called ocular melanocytosis, which you can see down here. This is also called nevus evoda. Patients who have this actually have a very high risk of development of melanoma, and we recommend that they are screened very frequently. Now, you might be referred to somebody for melanoma and not actually have melanoma. That also happens a lot. And so there are various lesions, spots or dots in the eye that are not actually melanoma. These can include choroidal hemangioma, chirpies, choroidal hemorrhages, metastatic disease, as you can see here, this is from lung, or even osteomas. This is a bony tumor that can form in the eye. And so let's jump in a little bit to the path to diagnosis. So often what happens in my practice is someone is told that there's a spot in the eye and they're going to be referred to the specialist. And then they find out that the specialist is an ocular oncologist. They hear the word oncology and start to have a freak out, although I see all different kinds of spots, including on the left here, which is a melanoma, and on the right is a nevus. So just because you have a spot and just because you're referred to an ocular oncologist does not already mean that you have a melanoma. What is an ocular oncologist? Well, an ocular oncologist is an ophthalmologist, which is an eye surgeon who has specific training in the management of benign and malignant tumors. Sometimes these people may also be retina trained or specifically ocular oncology trained. And so this is from a Google search that I did this morning of me to find my profile, but Google can sometimes be a great way to find someone. But you'll see if you look at people's profile, usually what you would see is somebody who says, like here, subspecialty training in ocular oncology. Finding an ocular oncologist sometimes is the first part of the journey to a diagnosis. Now, if you're in LA or in the California area, there's several of us in the state, but there are states where there are no ocular oncologists in the whole state. And so it's important to know that there are various means or mechanisms to identify a physician who has the skill set to treat somebody with a melanoma. And so this is from imelanoma.org, but it talks about all of these different areas where you can find an ocular oncologist, including from a Cure in Sight, the American Academy of Ophthalmology. There's some European sites, and then also the Eye Cancer Foundation. And dare I say it, in this day and age, you can also go to Facebook or Instagram. This again is from this morning. If you do hashtag ocular oncologist this morning, this is what comes up. And actually, you would see me in two of these. You would direct to my profile as well as to some of my colleagues. So once you get to your appointment, what should you expect? Well, ocular oncologists love imaging. And so you should expect that you will spend a significant amount of time with your eye being imaged. And that's usually not done by the ocular oncologists themselves, but rather by a team of dedicated ophthalmic imagers. They will take photos of the eye so that we can identify the tumor and the margins of the tumor. You may have something called fluorescein angiography or a dye test where they inject dye into the arm, or sometimes have you drink it orally so that we can see the vasculature in the tumor. And then sometimes you may also have something called optical coherence tomography or OCT. This is really done for us to understand the status of the retina, which is the structure overlying the tumor, as well as the extent of fluid, which you see is dark black here. And that can be very helpful, particularly in small tumors. You'll also have an ultrasound. One of the main questions my patients say to me is, Dr. Berry, why did they do the ultrasound on my eye? The referring doctor did it over my eyelid, and that varies a little bit center to center. But to get really good images, often you'll have a numbing drop placed on the eye, and the ultrasound will be done on the eye itself. Screening ultrasounds that are not quite so dedicated might be done over the eyelid, and we do the same thing. The ultrasound is a very sensitive modality for us to not only identify the location of the tumor, but to measure it and to understand which structures are impacted by its growth. Well, this talk is not at all about choroidal nevi. I felt like I should at least spend a minute on it because so much of the very initial referral might be regarding, is this a nevus? Is this a melanoma? And I think there's a lot of anxiety and misunderstanding as it relates to this for patients. So choroidal nevi, by definition, just like moles or freckles on the body, so nevus is a medical term for mole or freckle, are benign, meaning they are not malignant. And often the good nevi that we see in the eye might be dark brown or gray, they're flat, and they have no high-risk features. However, if they do have certain features, which we'll discuss, they really need to be monitored because all of these lesions could change at some point into a melanoma. And so choroidal nevi are actually relatively common. This is from a prevalence study looking across multiple publications and found that about 5% of an older Caucasian population will have choroidal nevi. And most of these tumors, so when nevus is still a tumor, it's just not a cancer, are asymptomatic. Again, this is another reason why you need to have that dilated yearly exam, because you might have a nevus and not know. But growth or change of this nevus might cause different changes that we see in the eye, which include drusen, changes in pigmentation, the presence of fluid, or the presence of something called lipofuscin or orange pigment is how we often describe it to our patients. And size also matters, but is not the definitive defining feature. So if you look in textbooks, most textbooks will say that a lesion around 5 by 1 millimeters is by definition of a choroidal nevus, although all of us who've treated melanoma have seen very small tumors in that range as well that are worrisome. And you can also have giant choroidal nevi, as you see here, that have been followed and are stable in the eye for years and years and years. However, they're quite large. So size alone does not diagnose someone as having a nevus or a melanoma by any means. But these nevi need to be monitored. And this is from a study by the Shields, who are ocular oncologists in Philadelphia. And there are some factors that tell us that there's an increased risk of a nevus turning into a melanoma. And that includes thickness greater than 2 millimeters, the presence of subretinal fluid, the patient noticing symptoms. Symptoms are usually a sign that something is growing or changing, the presence of orange pigment, and whether the tumor is close to the disc or on ultrasound looks hollow. So some of these features, as people who are listening, patients listening to this podcast might know because they're being followed for a nevus. And that includes the idea that it could be thick, especially thicker than 2 millimeters, whether it has fluid or orange pigmentation. And these are factors that, to me, mean, if possible, if you're in a place where a retina specialist or an ocular oncologist with training in melanoma can monitor you, they should. And the reason they should is that these grow. And so if you have 5 risk factors, you have a 27 times the risk that this nevus will grow. Growth is not a guarantee that it's turning into a melanoma. Again, you can have these larger nevi, but growth is very concerning for metastatic change, for malignant change. And we don't want to see growth unchecked and unfettered for this metastatic risk. So a growing nevus absolutely needs to be referred. And so again, just showing how important it is for you as the patient to understand these risk factors and to interact with your doctor to make sure that you're referred appropriately if you have one or more. Many times when I get a patient referred for this nevus melanoma question, the first question they ask me is, what about a biopsy? And again, I think this comes from the fact that 95% of the melanomas that we hear and talk about are these cutaneous melanomas. And so it's very well understood by patients that if you have an atypical mole or a mole that's changing, your dermatologist will take that mole out and have it biopsied for evaluation. And that works really well for moles on the skin because while you might have a small scar, you're otherwise okay. In the eye, I hope you see my mouse moving, but in the eye, there's the optic nerve and here's the fovea. And this mole, this was actually a nevus that's been stable now for a long time, but this mole is in between the 2 most critical structures for vision in the eye. So one, I can't take that out. If I take that out, I permanently destroy vision. And frankly, to take the whole thing out, I would permanently destroy the eye itself. So I cannot remove this easily. I could do a biopsy where I take a needle and take a few cells for analysis. It's still a very small tumor in a very critical spot, and so there's risks to the patient. But even if I do a small biopsy at that moment in time, and they tell me that the nevus is a nevus and it's benign, it doesn't mean that it doesn't need to be monitored, because in 2 years or 5 years or 10 years, it could still transform into a melanoma because it hasn't been removed. And so I spend a lot of time explaining this to my patients and making sure they understand this. I hope that in the future, we will actually use liquid biopsy to better follow these and to give some more definitive information to our patients. I'm not going to talk about that anymore on this podcast, but we did a podcast already on this. And so you can listen to this a little bit more if you're interested. So because we don't biopsy these currently, we monitor these closely. And why do we monitor these closely? Well, here is one of my favorite examples of this. So these are 8 patients that all have high-risk nevi. So that means a nevus or choroidal tumor in the eye that shows some features that are concerning we even as ocular oncologists are not sure 100%, is it a melanoma? Is it not? So we watch for a short interval. And you can see here, some of these, half, will be completely stable and not change, and the others will go on to change or grow. And that change or growth tells us definitively, this is an ocular melanoma. This is a patient who needs treatment. So when to ask for a referral, if you have any of those risk factors, or if you have any associated systemic disorders. So now that we've discussed the early diagnosis and the nevus versus melanoma tension, let's talk about some uveal melanoma treatments. And I thought I would give just a quick overview on the treatment timeline and the history of treatment of melanoma. So prior to the 1960s, enucleation was the primary diagnosis in the US. And I like reminding people that because the 1960s weren't really that long ago, right? And so a lot has changed in this rare disease in a short period of time. And even in the 1960s, unfortunately, there was about a 20% misdiagnosis rate. It might have been other things that were growing or changing in the eye. So we've gotten better at diagnosis and better at treatment. In the 1970s, there was some thought that the enucleation itself, the manipulation of the eye, caused tumor spread. Now, that has been completely debunked. I don't want anyone to worry about that. We know that that's not true. But that led people to think, okay, is there something that we can do that is not going to cause tumor spread? Again, take home, it was not causing tumor spread, but they wanted to see if there were any other options to manipulate the eye less. And in Europe, people were doing plaque brachytherapy or various forms of radiation therapy to the eye in order to save these eyes with melanoma. So in the mid 1980s, again, not that long ago, I was alive, right? We in the United States designed the collaborative ocular melanoma studies in order to specifically evaluate whether it was safe to treat patients with this form of radiation, where you take a plaque loaded with radioactive beads in order to save the eye. And these were very well designed, long prospective studies funded by the National Eye Institute. And there are many collaborative ocular melanoma studies, but the three main ones were basically the large, the medium, and the small tumor trial. And the idea for the large tumor trial was, does a patient after they have eye removal need radiation? Because a lot of radiation was being done at that time. And we found that there was no added benefit to radiation. So this is why we do studies, right? To really understand, is something helping a patient? Is it hurting a patient? Is it not doing anything? What should we do as a group? And so the large study helped us move away from radiation after the eye was removed. The medium study ushered in a whole new era of saving these eyes. Again, prior to this, the treatment was to remove the eye. They looked head to head at eye removal versus brachytherapy and found that the outcomes overall, in terms of the patient surviving, not the eye, but the patient surviving, were equivalent, and that it was safe to offer eye salvage therapy for patients with medium-sized tumor. And then for the small tumors, again, specifically because of this tension in some of the small tumor studies, the idea was, can you safely watch and monitor these? And the answer was yes. The risk at 5 years in terms of overall patient survival is low. We know we can monitor them to make very sure that we're dealing with a melanoma before treatment. Around that same time in the 70s to 80s, proton beam, which is another form of radiation that is external, it's charged particle radiation, and a beam of that is literally placed into the eye to target the tumor, was also gaining popularity. And the first was the Harvard cyclotron. And by the mid 2000s and now even past, there's 20 or more centers that do this type of radiation therapy for ocular tumors. So the charged particle irradiation has some advantages to brachytherapy in that you don't have to have two surgeries, and the surgery that you do have is somewhat smaller to place clips in the eye. It gives a very uniform dose of radiation, but it also radiates all structures from the front to the back of the eye, where the brachytherapy radiates the structures local to the tumor and not so much to the front of the eye, unless your tumor is in the front of the eye. In the late 80s to current, people, including USC, where I have my ocular melanoma practice, started to look at various forms of plaque brachytherapy to make the treatment of brachytherapy even better and even more localized. And they designed the USC iPhysics plaques, which are frankly one of the most common plaques now done throughout the US and the world. And again, I played no part of that, but I get to benefit from using them. We call these personalized eye plaques. So you talk about personalized medicine. It means you take information about the patient, you design your treatment to that. These personalized plaques are similar. So we take imaging from the patient, make a 3D model, and design the plaque around the patient. So it is not a one-size-fits-all plaque. You are not getting the same plaque as the person who was treated several weeks before. The size, shape, and dosage is really for the patient and for the patient's tumor. And that's done to limit radiation toxicity to other structures in the eye. And so there's a 3D modeling process that's used for this to overlay the plaque onto the tumor in the eye using both the ultrasound and either a CT scan or an MRI of the area called the orbits, which is the area around the eye, again, to make sure that that plaque is fitting within the patient's ocular space to best treat their tumor. And then we use very specific markers to make sure that during the surgery, we know exactly where to put the plaque in the eye. So I'm going to share, I think I have time. Yep, I still have time despite a little cough. I'm sorry again about that, but I'm going to share a 2-minute surgical video of placing a plaque. So if you are sensitive, you don't want to see an eye surgery, please close your eyes or turn away. Once it's done, I'll let you know. And it moves fast. This is 4 times speed. I don't actually operate this fast. So this is showing the 3D process of taking the images from the CT or MRI and the ultrasound to perfectly design a plaque for that patient's eye and that patient's tumor to give the highest dose of radiation to kill the melanoma without as much radiation to other ocular structures. It's not zero, but we try to limit. People ask, how do you get into the eye? Well, you have a skin on the eye called the conjunctiva, and we open that up. And then very delicately, we mark the exact location. This is an ocular muscle. I don't always have to take these off, but I like to show that sometimes you do. And then you mark again using the plan. It's all planned out. You know exactly where the patient's tumor is. You mark where the plaque is going to go on the eye wall. That white part of the eye wall is called the sclera. And it's about 1 millimeter or so thick. It depends on which part of the eye you're placing those sutures. But you place that just there on the eye wall. And the first thing you do is put a dummy plaque in. So you saw that was hollow in the center. You make sure with ultrasound that that plaque is exactly where you want it to go. It's covering the tumor nicely. And that's when you put the heat on. You put the hot plaque on that has the radiation seeds. You suture or tie it down in place. You close everything up, and then the patient goes home. The timing of plaque is dependent a little bit facility to facility, but then the patient comes back and it's removed in the OR several days or a week later. And here you can see gently releasing those sutures. The plaque removal, I do my plaque removals in the OR. I think it's more comfortable for patients, but that's not done everywhere. You remove that plaque. It's again a very quick thing. You close everything up and the patients heal up really nicely. So let's talk about some options for treatment today based on size of tumor. So for patients who have small tumors, again, brachytherapy or proton beam, we've just gone over the history of both of those and the way those two mechanisms of radiation are applied, are standard of care treatments for small, medium, and even large tumors. However, we're in an era now where we have more trials, which is really exciting. And as somebody who treats these tumors, these didn't exist, 10 or more years ago when I started my practice. And so I'm really excited about them. One such trial is the COMPASS trial. Again, I am not sponsored by Aura. I don't work for Aura. I'm just sharing information about this trial. And I actually, if one of my patients is interested in this trial, I send them out to an enrolling center. So what happens in this trial is there's an injection of a medication into the eye called Belsar. It's a novel therapeutic that sort of has a virus component to it that allows an affinity for these tumors. And then there's a laser, and the laser actually activates the drug right in the tumor. As ophthalmologists, we're all very good at aiming laser beams into the eye. We do this for lots of indications. And so we can then very specifically activate the drug over the tumor. However, for you to be eligible for a trial like this, you need to have a small small tumor, the tumor thickness needs to be less than 2.5, but also more than 0. We want to make sure that we're actually treating these high-risk early lesions and small melanomas. And you also need to have some documented tumor growth, again, for that same reason. So you can follow the QR code to find out more about that trial here. In general, for the medium tumor trials, again, brachytherapy and proton beam are standard of care, although this is changing a little bit as well with some early news from some of our large tumors. And this includes a trial from IDEA Biosciences. And so in this trial, they're using Daro, which is an oral medication. It's a small molecule inhibitor of protein kinase C, which is something that we know to be activated in these melanoma cells. And so you can turn it off. This is also actively enrolling for patients who have tumors that are planned for enucleation or brachytherapy. And hot off the press, as of June 3rd, the company released some early results from their initial trial. And what they found is that from 12 patients who were planned for enucleation or eye removal, 9 of them were able to preserve their eye by taking Daro for 6 months beforehand. And so their take home was that this is not taking the melanoma away, but it's providing meaningful shrinkage of the tumor to either avoid enucleation or provide a smaller dose for brachytherapy. And so this is evolving. Lots of more information will be released, I'm sure, in the future. At the time of whichever treatment you choose, most physicians will talk to you about a biopsy. Now, it is my practice to offer a patient a biopsy, but let them choose whether or not they want it. Most of my patients, but not all of them, do. And for very, very small tumors, like less than 2 millimeters that are right next to the fovea, I might not want to biopsy those patients because I think the risk may be greater than the benefit. The likelihood of them having a high-risk tumor profile is low, but this is all something that you need to understand and to talk to your doctor about because there are options here. And as the patient, you should be empowered to activate those options and make a choice that's right for you. So the biopsy that's done is usually an FNAB. That means fine needle aspiration biopsy. So again, doesn't mean we cut the whole tumor out, but instead it means we take a small needle about the size of, 10 or more human hairs put together, place it in the tumor just to take some cells out. It is in general, again, not done for diagnosis. We already talked about that as it relates to the nevus versus melanoma question, but rather it's done for prognosis. And the prognosis that we're looking at right now is the prognosis that this tumor will show up in the body in the future. So prognosis for metastatic disease. In my practice, the biopsy mechanism that I choose to identify prognosis is use of Castle Biosciences. Again, I don't work for Castle Biosciences, but Castle Biosciences uses a gene expression profiling assay, which basically means it tells us which genes are turned on and which genes are turned off in the tumor. And we know from very good studies that this helps us prognosticate how likely it is that the tumor might show up in the body. There are also, aside from class 1 and class 2, there's also BAP1, monosomy 3, and PRAME. This is other information that you may get. Some of this comes from Castle. Some of this comes from other types of biopsy, like cytogenetics, that may be offered to you at your center. So just understand if a biopsy is offered to you. If it's not, you should consider asking for a biopsy and understand what kind of biopsy it is and what are the biomarkers that you are going to get. From Castle, this is the kind of results that are given to the patient. Patients with class 2, of course, have higher risk of developing metastatic disease. And then you're in a good position to really understand what sort of surveillance you need as a patient. And so other factors that are clinical also impact your risk of metastatic disease as a patient. And that includes age, involvement of the ciliary body, the size of the tumor, both the thickness and the diameter of the tumor, and again, that chromosome 3 status. Chromosome 3 is higher risk. But what has shown in several studies to be the most predictive is, in fact, this gene expression profiling class. And so that is why in my hands, this is the test that I use. I also, at diagnosis, stage my patients. So I cannot tell you how often I'm asked, well, Dr. Berry, I already have an ocular oncologist. Why do I need another oncologist? Well, cancer in the eye, I believe, should be staged in the same way that cancer anywhere else in the body is staged. And so the American Joint Committee on Cancer is the group of researchers and physicians that come together to provide staging guidelines for patients with cancer. And those guidelines are specific to each type of cancer. And so for melanoma, the staging is based on the size and extent of the primary tumor, but also whether or not there's any sort of metastatic disease found in the body at that time. To determine that, you need to have baseline staging scans. In my hands, I generally do a CT of the chest, abdomen, and pelvis. Other places might do something different, but that's my preference. And then again, particularly if I'm planning brachytherapy, I will get that imaging around the orbits. Now, I have heard via some patients who come to me or at academic meetings, people will say, we don't need to stage these patients with melanoma because the risk of them having metastatic disease at diagnosis is very low. And that's true. Thankfully, the vast majority of our patients do not have any metastatic disease at diagnosis. However, we do know that with this cancer, many patients, unfortunately, will go on to develop metastatic disease. So I believe that it is important to have that baseline staging and to partner with a medical oncologist and have the patient followed with a medical oncologist. I don't want to get a 5 p.m. Friday call, Dr. Berry, the ultrasound showed something in my liver and I don't have someone to call to help me. I can't treat liver disease. So I feel that it's really important to have a team-based approach. And thankfully, one of my colleagues from the other side of the country will be talking to you guys about this shortly. The last thing that I'd like to talk about before we move on to some Q&A and then before I hand off to Dr. Orloff for her part of this webinar is another really common question I get from my patients. So their question is, well, what treatment, all this sounds great, Dr. Berry, but which of these treatments is going to bring my vision back to 2020? And unfortunately, the answer right now is that we do not have a treatment that is going to restore someone's vision to 2020. And in fact, unfortunately, the radiation therapy that we do is really very good, 98% or better at killing the main tumor in the eye, the melanoma that's formed in the uveal tract, and maintaining it. So that's really high success. We're really good at that. But the dose that needs to be used to kill the tumor is a dose that can cause damage to structures in the ocular space. So as I discussed, there are many people around the country and the world that are working on different ways to maximize the dose of radiation that's needed to the tumor itself, but to decrease it to the ocular structures. And so we've done that with the USC Eye Physics plaques, the IDEA trial that I discussed. So the idea there is you shrink the tumor down again to prevent enucleation, facilitate radiation, and to decrease the dose of radiation that might be needed for an eye, all with the goal of maintaining as much vision as possible. Other things like diabetes, young age, use of chemotherapy might impact vision. And there are also some ongoing trials, including some that I hope will be opening up later this year or in 2025, looking at injections or other therapy for patients. Unchecked, you can see that radiation can continue to cause damage in the eye. So again, this is why it's really important to be in a place where you can partner with your ocular oncologist, the retina specialist who's treating you to maintain the vision, and with the medical oncologist to monitor the body. So in conclusion, uveal melanoma is a rare tumor. You need a team, and you need a team with training for this rare disease, including an ocular oncologist to diagnose and manage the eye, including the treatment sequelae as it relates to vision. Thankfully, we have new trials for better treatment salvage. And I think it's really important that each patient understands the role of biopsy, whether they want a biopsy, and if a biopsy is being done, what in their case is it looking for. This is from our team and my two daughters, Daphne and Lily. It's a real honor for me to be part of the ocular oncology community. I spend my days doing melanoma in adults and then retinoblastoma in children. It's very rare to basically focus on two diseases as a physician, but I love it. Our team loves it. And we're so honored to take care of these patients and to be here and share our experience with you all. Thank you.
Dr. Berry, this was fabulous. I absolutely loved everything. I feel like I learned a ton, even as a patient 4 years into my diagnosis, who my job is, to be as immersed in this as some of you guys are. And so I loved this. Thank you so much. Please make sure that if you are asking questions, that we are not able to give personal medical advice, but we can give generalized medical advice. So we'll do our best to answer those questions as we go.
I am a physician that treats diseases these diseases, and I treat them at USC because I shared that. But I'm not speaking to you today as your USC physician. I'm speaking to you generally to provide education to the melanoma community. So I can't answer some more specific questions, but I can give some general advice and education.
Wonderful.
Kevin says, hi, Dr. Berry. Next Tuesday will be my 5-year anniversary of biopsy for ciliary body. I had Castle GEP and next-gen sequencing, resulting in class 1A and only one small missense in GNAQ. That's great. That means that you have a very low risk profile. It says, still no Mets. Also really good news now at 5 years. What is your recommendation to patients on Castle prognostic genomic testing at first biopsy? So yes, this is my recommendation as it relates to my practice, is that I do use this prognostic genomic testing. Again, I have patients who do not want this information. I do not force it, but I do provide it as something that I can do for them. When I started out, we didn't have adjuvant trials. Adjuvant means trials after the primary therapy, but we do now. And some of those trials want to know that the patient has these high-risk markers. So, for example, they would want to enroll somebody with class 2 disease because it may make sense for someone who's high risk to have further therapy after their primary ocular therapy. So I make sure my patients are informed about that. We have the trials that are available in the office and I can share it with them. I also recommend, again, that anyone, particularly who has a high risk biopsy, but really all my patients partner with medical oncology. There is also a question, and maybe you're getting to it, what do you do after 5 years? Well, I think it depends also a little bit on patient's age. So if I have a 27-year-old who's now 32, 5 years out, I'm absolutely going to strongly recommend that they continue surveillance. I am lucky that I also get to treat people who might be 105. And so they might say, I'm kind of over this. And I think that's okay. Really, just like I like to personalize our plaques, I like to personalize my medicine for what the patient needs. But it's good news for you, and I'm glad to hear that. So our next question is from Heather, and Heather says, is one eye injection better than another? That is a great question, and we are studying that. So again, the ocular oncology community is coming forward to do a prospective trial of this. The lead person who's looking at this is Dr. Arun Singh. So if any of you have been treated by him or know him, he's a big name in the melanoma community. We honestly don't know for sure when you should start injections. Should the injections be steroids or should they be an anti-VEGF medication? How often should you give injections? How long should you continue injections? Should you do laser? Every single bit of information that we have as it relates to that are from small studies that are often retrospective. They're center by center. And even among my colleagues, our approach to this is different. We don't have a good head-to-head prospective trial, but we will have one soon. And I think it will give some good information. In my hands, for most patients, I don't treat until I see signs of retinopathy. Some treat earlier. There are multiple reasons for that. That's just my practice. Although in very young patients or patients who ask about it, we talk about it. And then we talk about, some of the real life stuff, like what are the insurance implications? They might not cover an injection if you don't actually have signs of treatment. So doctors hate talking about things like this, and we just like to provide care, but I think it's an important dialogue with patients. So the answer is we don't know.
I think you kind of covered. It's about Avastin and injections. We kind of covered that one already, but if there's anything else you want to add, feel free.
Yeah, I think, when patients do start to show signs of radiation changes in the eye, I think it's very reasonable to try Avastin. That's usually my first line, or another. And again, no company, I don't work with any of the companies that do any of the injections. So that just is my practice. And you can also use steroids. So sometimes if there's been a really big tumor and quickly the eye is showing a lot of fluid, it's something called tumor necrosis syndrome. It means your surgeon did a great job. Your tumor is dying, but as it's dying, it causes a lot of inflammation. And so an injected steroid can sometimes help there. But talk to your doctor about what the options are. Okay, so Sandra asks, why is cytology not done with the biopsy taken during brachytherapy to determine malignancy? So that's also a great question. There's a couple of reasons for this. So first of all, the tumor biopsy is, again, small. You're taking just a couple of cells. We generally want to prioritize getting the prognostic information. And so again, sending for genetic or genomic alterations via whichever company your surgeon likes to use, and they can talk to you about that.
I was just going to ask, can we define the word cytology?
Oh, yeah, that's a great question. So cytology means looking at cells, like a cell prep. Like for women, if you've had a pap smear, basically what they're doing is taking cells off the surface and then looking at the cells under the microscope to see if they're malignant. And so for the tumors in the eye, you would then have to go in again and do a separate biopsy. If you have a big tumor, that's probably not that big of a deal. But if you have a smaller tumor, entering multiple times with a needle does cause increased risk. And you've already been diagnosed, right? The ocular oncologist is doing the treatment. They've already made the decision that you show the clinical signs of a melanoma. And the worst thing that can happen is sometimes the cytology goes off and they say, we didn't get enough cells, or we're not sure, or melanocytic cells, nevus versus melanoma, correlate clinically. That's a common report we get. Well, correlate clinically, we already correlated clinically. And so that's why it's often not done. Again, my liquid biopsy work will not look at cells. It'll look at markers from cells, but I'm hoping in years to come, definitely within the next 5 to 10 years, it'll be a more frequent thing that's done clinically. Roger Shore, what is your recommendation about follow-up MRIs to monitor potential mets? So I work with ocular oncologists most of the time, an oncologist, Gino In at Norris Cancer Center, and he has expertise in melanoma. And we make these decisions together based on the patient. So based on how high risk the patient is from their biopsy, if they are higher risk, we recommend MRIs. If they are lower risk, they might still get an MRI, but not as frequently. If a patient is fit and can have a liver ultrasound and they're low risk, sometimes we choose that. It really just depends on the patient. You'll have patients who can't tolerate MRIs for one reason or another. And so you really have to discuss with the doctor your specific risk. Yes.
Just kind of to add to this question, in your opinion, is it best practice to have both an ocular oncologist and a medical oncologist who, specifically is focused on the scan monitoring? I just know that sometimes I hear about patients who their ocular oncologist is the one ordering their scans for like 5-6 years. And while I kind of am curious, do you think that that's okay? Do you think there's a benefit or a risk to that?
Yeah. So that is not my practice. And the reason that I gave earlier is why when I first started out, that had been my training. And so I did that. And like, you feel good, like you're the doctor taking care of the patient, you're doing everything. And then a patient will call you on Friday at 5 p.m. and say, there's a new lesion on my scans. What do I do? Well, now you're scrambling to get the patient into a medical oncologist, scrambling to set up a relationship. It's highly anxiety inducing for the patient. And frankly, ocular oncologists who are practicing in this field, like, we care about you guys. So it's anxiety inducing for us as well. I want my patients to have an established relationship. I will say, I probably shouldn't, I don't want to get into trouble, but I will say insurance dictates a lot of this and it can be hard. So I have many patients whose insurance will not allow them to see my medical oncologist. The medical oncologist that they see might not be as well versed in these rare melanomas. That's not their fault, right? They're probably a wonderful medical oncologist. They just don't treat these rare diseases. And then you find yourself in a tough situation. I had a recent experience, and I know the patient would be okay with me anonymously sharing these details, but the patient was being treated with an older protocol, Ipi-Nivo, for metastatic disease, and there had been no discussion whatsoever about Kimmtrak, no testing for HLA. And again, it really is not the oncologist's fault that that person does not do uveal melanoma, is not an expert in it. they are put in an uncomfortable situation as well. And so we really had to work together to get the patient in with a medical oncologist like Dr. Orloff, who understands the current best practices for uveal melanoma. So important for you all to understand that as well.
Oh, I feel like that's such a nuanced answer. Like it's very particular, very unique to each patient. So thank you. We have time for one more question. So if you want to take a look at the 3 that you see and pick the one that you want to answer the most, and then the other 2, I will send those over to you if you're willing to send an email response in answer.
Yeah, sure. Well, it seems like I can answer all of them, I think, in one answer, because they're sort of like they're large tumors. How fast do they grow? So in general, we don't think these tumors grow very fast. That being said, people really get stuck on this idea that if my tumor had been diagnosed 3 months or 4 months earlier, I would have a completely different outcome. And a lot of good studies have shown that that's just not true. That is unlikely to be true. So a delay in diagnosis of years, and by the way, I'm saying multiple years, surely is impactful. A delay in diagnosis of months is very unlikely to be impactful. These are not fast or rapidly growing tumors. And yes, we do know that some tumors are heterogeneous, but by and large, there is a dominant clone, and that dominant clone is what's driving your risk. And so that's why we believe that biopsies, not just for this tumor, but for every cancer, have a role. So people like to kind of pounce sometimes on heterogeneity, but then you look at our breast cancer patients, all of our patients, we use biopsy and we use markers to prognosticate risk and to, I'm hoping we'll get there, to identify treatment that is best for those tumors. We don't stop doing that just because there might be some small levels of heterogeneity. What's dominant is dominant. Just like you might have some changes in your personality, you might be shy sometimes and not shy other times, but how you are in general, that's your dominant clone. And so you can think about tumors the same way.
I think that's such a good way to explain it. Well, Dr. Berry, thank you so much for answering all these questions, for this presentation, for the information you shared. If anyone has specific questions or wants to get in touch with you directly, is there a good way for them to do so?
Yeah, absolutely. So I am online. So I blog and I talk as much as I can about ocular oncology on Instagram at Moda _MODA_MD. I cannot provide medical advice there, but I can provide education, or you can reach out to me via USC. I do accept patients for specific questions there as well.
Excellent. Well, Dr. Berry, we thank you for your time. Thank you for those of you who tuned in live, and this will be recorded. You can catch the recording on our YouTube channel and on the I Believe podcast at your listening channels at your pleasure. For now, though, I'm going to go ahead and let Dr. Berry get back to her day, and we're going to bring on Dr. Marlana Orloff from the other side of the country. You're right.
Thank you all. You're going to end this wonderfully with my colleague, and I really appreciate you guys sticking with my cough and letting me be here. Bye.
We have Dr. Orloff. Hello. How are you, Dr. Orloff?
Hi, everybody.
All right. Well, like I said, this is Dr. Marlana Orloff. She is joining us all the way from the other side of the country on the East Coast in Philadelphia at Thomas Jefferson Hospital with the Sidney Kimmel Cancer Center. So Dr. Orloff is a medical oncologist, and we are thrilled to have her here to talk about navigating a uveal melanoma metastatic diagnosis.
I think Dr. Berry, summed up things great there just in the last few minutes that, there is a little bit of a baton pass, that happens after a patient has a new diagnosis of metastatic uveal melanoma. Normally that baton pass is kind of most seamless when the patient already has a relationship with a medical oncologist. And I'll talk a little bit about that, but we certainly are grateful for our ocular oncology colleagues who will also pick up the phone and call us if one of their patients has a new concern. So thank you, Dr. Berry, for kind of setting the stage, and we will jump right in. So as Danae mentioned, the title of my talk is Navigating a Metastatic Uveal Melanoma Diagnosis. So what I wanted to do is really kind of set this talk up in chronologic order, kind of based on how one actually experiences a new metastatic diagnosis. And so I don't necessarily go into detail about surveillance and what leads up to the suspicion. I think part of that was part of Dr. Berry's talk. And then also today is really not meant to be a discussion of all of the data, including recently reported trials or trials in progress. I actually encourage you, there's lots of other webinars I think that have been on this topic. And I will say that actually here at Jefferson, we're having a patient symposium for which a Cure Insight's actually going to be there just tomorrow. You can only attend in person, but it will be recorded and then available online as well. Where kind of each of of the treatment approaches to metastatic disease actually has its own session. So a lot of the information can be reported there and has been also detailed elsewhere in other webinars. So really, like I said, today is really just kind of going through, the navigation checklist of kind of what the steps are that someone may experience and kind of how to think about those if you're in the middle of it, going through this, or certainly, unfortunately, have to go through it in the future. So here you can see kind of an outline for the talk. So, with things like Epic and other electronic medical records, it is honestly often the patient who gets an alert on their phone that a radiology read is available for review and may actually see the report before the physician. Certainly, if my patients are getting their scans outside of Jefferson, it's going to end up in whatever local portal exists there before it ends up getting either electronically sent over to my in-basket or even old school paper fax and then uploaded. And so, what I wanted to kind of highlight here is that, that you get the alert that the MRI report is ready for review. And for those of you who've had the experience of reading MRI reports, you want to scroll down, you want to see the impression saying, no evidence of metastatic disease in the liver, right? That's what we all want to see, every time we get a scan. But unfortunately, there are times where even if you've had a bunch of negative scans, the impression is not that. And the impression may be something as kind of definitive as, extensive hepatic metastasis with, a large mass. It may even suggest that there's cancer outside of the liver, and what that translates to is what you can see here on the right is, this being an MRI, this being the liver, here the brighter white being normal liver, and then the dark spots here, these circles being tumor, and then actually this whole left lobe here is a tumor. So this is not subtle. There's no kind of clinical confusion about what's happening here. We would still offer biopsy for this patient to confirm, which we'll talk about in a second, but this is pretty obvious. On the opposite end, there are times where a patient could have had an MRI, multiple MRIs, or maybe their first MRI. And the impression is there appears to be a new lesion in the left lobe, measuring often under a centimeter, but given the history of malignancy, METs cannot be excluded. Close interval follow-up is recommended. So here the radiologist is actually saying, while we think this could be METs, close interval follow-up is recommended. And there are times where close follow-up is recommended, but, oftentimes we do actually aim to biopsies. So if someone's undergoing close surveillance, so certainly the high-risk patients who are being followed, say, every 3 months with MRI, it is not uncommon for an MRI to pick up something that's new under a centimeter, in which case biopsy may be difficult. Sometimes the urgency for a biopsy may be dependent on how suspicious something looks, the size of it, the location. Though we tend to say that anything new or growing, certainly in the liver, needs to be evaluated and biopsy at least attempted. If it's outside the liver and it's a lung nodule, we often actually monitor those, I would say, for longer. Someone may have a couple of new 3-4 millimeter lung nodules. It is unlikely that's usually related to uveal melanoma, not to say that it's, never uveal melanoma, because we certainly have patients who present with lung metastasis first, and that's like a whole different kind of subset of patients. But there's also a lot of other things that can cause lung nodules, bad bronchitis, or, certainly we were seeing it a lot during times of COVID. So not every lung lesion is uveal melanoma, but, in someone with history of eye melanoma, it's usually any newer growing liver lesion really is uveal until proven otherwise. Lung lesions, if they get big enough, over a centimeter, we will often recommend a PET scan, which we normally don't do, at least in my practice, for the liver. And I would say of all the patients that I've evaluated for uveal melanoma who've had a new lung lesion, I've probably actually picked up incidental lung cancer, probably more than first diagnosis metastatic uveal melanoma. So they still need to be worked up, still need to be biopsied if suspicious, but they are a little bit of a different breed. In our practice, basically because I have an interventional radiologist who's very good at ultrasound guided biopsy. If a lesion is greater than 7 millimeters and location appropriate, biopsy is often feasible. If it's sizable, but the location's hard for ultrasound and percutaneous subcutaneous biopsy, we sometimes send to a surgeon for an exploratory kind of laparoscopy where they can look at the liver and get to areas, sometimes even use intraoperative ultrasound to get a biopsy there. But if it's small or hard to access, then actually scans at 2-month intervals, so that close interval follow-up that the radiology suggested, can be reasonable. Even if we can prove metastatic uveal melanoma for a lesion under 1 centimeter, it does actually pose some challenges for treatment decisions. So often things under 1 centimeter are too small for clinical trial, sometimes even too small for certain liver-directed therapies. And, we'd certainly have patients where we may say, you know what, let's wait until it's over 1 centimeter to biopsy. Or even if we biopsy it at 7 millimeters, we say, oh, but there's a first-line clinical trial that we really want, to wait for, so we may get another scan and wait for it to get over 1 centimeter, which I know seems crazy. And for those of you listening who've kind of been in that limbo, it's an uncomfortable place to be, but it is a little bit of kind of a diagnostic and then kind of treatment conundrum that we sometimes find ourselves in. The truth is, though, if lesions are multiple and sizable, you shouldn't be waiting to biopsy. And I guess this also goes to the point, and I didn't put a bullet here, but it is our practice that we do not treat without biopsy confirmation. There have been patients over the years that, even though it looks like uveal melanoma, it turns out to be something else. So sometimes you pick up things like chronic granulomatous disease, which is kind of a type of inflammatory process that can happen in the liver, in which case, we obviously would not then treat for metastatic uveal melanoma. So biopsies are necessary, certainly required for clinical trials, and then required in our practice for treatment. So the next thing kind of in the checklist that I had mentioned is something called HLA testing. So I think for those of you who are not new to the uveal melanoma community, heard about HLA testing. What is HLA and why does it matter? We'll talk about that. So HLA stands for human leukocyte antigen, also called MHC. It encodes cell surface molecules that are basically responsible for presenting bits of antigen to T cells. So antigen can be bacteria. Antigen can also be tumor. And the immune system really kind of uses HLA to differentiate self versus non-self. But here in kind of cancer fighting terms, it's really the MHC or the HLA that presents bits of cancer to the immune system. And then in theory, the immune system should recognize it as being a bad guy and kill it, as you can see by the diagram there. So why does it matter in uveal melanoma? Well, because really the only systemic drug that's specifically approved for uveal melanoma, something called tebentafusp, is what we call HLA restricted. So in order to be eligible for tebentafusp, you need to be specifically HLA A201. And so testing for this really should be offered to all patients either in the surveillance period or at first metastatic diagnosis before treatment decisions are made. There are many different types of HLA. And so in order to develop kind of this drug that you can kind of see here, it's kind of this ImmTAC, this blue guy here. It needed to basically be engineered to interact with a particular HLA that would present the peptide, because there's this linking that has to happen in order for the T cell to then kill the cancer cell. And HLA-A2 is the most common, found in all ethnic groups, and O201 is the most common in Caucasians, and of European descent, which make up a bulk of patients who are diagnosed with uveal melanoma. So I just wanted to kind of take a step back, and I think Dr. Berry started to kind of allude to this, and that why it's so important to seek care at an expert center or have a medical oncologist who's in touch with folks at an expert center, or even if you have a local oncologist, to kind of have your foot in the door at an expert center. And that's really because, in uveal melanoma, it's rare. You've probably heard about the incidence and prevalence, not only in Dr. Berry's talk, but elsewhere. But in the metastatic realm, there's really growing complexity in the treatment landscape. And so I think it's really important to be at a center that has knowledge, at least, of the broad landscape. So, not only knowledge of melanoma as distinct melanoma subtype, obviously different from skin melanoma, knowledge of treatment indications and criteria. So, knowledge of what HLA is and why having that information is important, knowledge of standard of care treatments and ability to offer or refer when unable to offer. So, not every oncologist in the US is able to offer tebentafusp. It is a little bit quirky and unique in that there's, some inpatient hospitalizations and prolonged monitoring period with the first 3 doses. But at least if a site is aware that the drug exists, if they can't offer it themselves, at least be able to refer to a site that can. Knowledge of clinical trials that are open now and in the near future, and really knowledge of inclusion and exclusion criteria of those trials. So, the last thing we want patients to do is to get a treatment, say, immune checkpoint inhibition kind of as a first choice because the medical oncologist may not be aware of what's out there, that then makes them ineligible for a trial. We do have a first-line trial right now that I'm going to detail that's very specific to AA2 negative patients, but you can't have had prior immunotherapy because that's actually a comparator arm. So, you don't want to be somewhere where something may be offered that then could exclude from treatments down the line. And you don't always have a crystal ball, but at least someone who's, willing to, like I said, reach out to an expert center who may have those ideas. And there are opportunities to seek recommendations from an expert center and then get treatment closer to home. So I gave the example of tebentafusp. So there's a lot of sites that may not offer the first few doses because of the complexity of the prolonged monitoring period. But we have a number of patients, actually probably almost 3/4 of our patients who come get tebentafusp induction at our site. We then actually refer to an oncologist closer to where they live. And that works out really well. Standard of care immune checkpoint inhibitors. So if things like your Opdivo, Keytruda are recommended, those can certainly be done closer to home. There are some liver-directed therapies that can be done closer to home. Obviously now with Hepzato being FDA approved, in theory, it could be done kind of anywhere, but it's also kind of a unique treatment and it's not necessarily being offered everywhere. But things like radioembolization and Y90, because it's offered for other cancers, often can be offered at a local hospital. However, despite kind of having some of those options, as many of you know, there's still often a need to travel for clinical trials or even sometimes just basic treatment. And just sometimes really just the comfort of being somewhere where that even if you start on treatment A, they could potentially offer you then treatment B and then treatment C and not have to be kind of going to multiple sites. So I started really framing a lot of my talks kind of around this, because this is really what ends up going into the decision making, both kind of with the patient and then also actually behind the scenes. When we talk about patients and talk about, what treatment approach may be best, there's really 5 things. So HLA status, which I'll go into a little bit more, though we already talked about it, the sites of metastatic disease, how quickly things are growing and how much tumor there is. So what I call burden and kinetics, clinical trial availability, and then really something I've kind of titled as logistics. And so these are all kind of things that we kind of throw in the pot, when we're trying to decide what treatment may be best for a patient. So one of the first breakpoints, as we noted, is HLA status because of the availability of tebentafusp. So if someone's A201 positive, they are eligible for tebentafusp. There are other HLA restricted options. So there are other clinical trials that may enroll specifically A201. And then there are actually also trials now or soon to be enrolling for another subtype called A24, which is kind of one of the more common subtypes as well. So having your HLA type, not just knowing if you're A201 positive or negative, but actually knowing kind of what HLA alleles you have could be helpful for treatment options. And then if you're A201 negative, in theory, all of the other options outside of those that are restricted to A201 are an option. And then very specifically, there are trials for patients who are HLA A201 negative. So having that information out front right before first line treatment is really important. So the current options to treat them kind of based on HLA status, I already kind of said this in so many terms, you can see it here. And, tebentafusp, again, I'm not going to go too much in detail. There are full hours available online where you can learn all about tebentafusp and other webinars. But more recently, we did publish the 3-year overall survival. Tebentafusp was compared to the control arm, which was single agent immunotherapy or chemotherapy. And what you can kind of take home from here is that even going out now 3 years or more, there's still kind of a break in the survival curve. So with more patients alive in the tebentafusp arm than the control arm. Some of the other things, that were originally reported haven't changed a whole heck of a lot. We still don't see a ton of response with tebentafusp. So you can see, only one patient had a complete response, patients who've had partial response, but a lot of patients having stable disease, especially when you compare it to the control group. And it's really these patients too with stable disease, or even if their best response was progressive disease and then kind of plateau, still showing kind of an improvement in overall survival compared. And then this is, again, just showing that even patients who have progressive disease tend to do better than those who had progressive disease in the control, probably due to phenomena and sometimes progression before kind of plateau or other things that we still haven't totally figured out. And then what you see here is, in case this has come up in discussion with any of your medical oncologists, is that at least on the trial, we looked at something called circulating tumor DNA. And there was a thought that correlation of kind of outcome and survival with log reduction in circulating tumor DNA correlated better than actually radiographic response. So there are some folks that are checking ctDNA kind of in practice. The platform that was used in the trial is a bit different than the one that's commercially available. So it's hard to know if it'll kind of stand up compared to what was done in the trial, but for some patients, it can be a useful tool. So like I mentioned, there are other HLA restricted considerations. The most common HLA in most of the trials will restrict for A201, but they'll look out for an expansion to A24 and potentially even other HLA types. So even if you are not A201 positive, like I mentioned, there is a first-line trial that's actually enrolling specifically A2 negative patients. So this is the randomized trial looking to get kind of registration or FDA approval of the combination of darovasertib and crizotinib. So it's a 2-to-1 randomization. You need to be A201 negative, and then you're randomized to either get darovasertib and crizotinib or investigator's choice, which I think for the most part, at least in the US, is Yervoy and Opdivo. So why are we excited about darovasertib and crizotinib? And that's because, we've been doing the trials for actually quite a long time, initially with just darovasertib, also called, some of you might have heard it as IDE 196, and then in combination with crizotinib, which is actually a drug that's approved in lung cancer. And when we were doing the other trials in patients who've been previously treated, you can see by these waterfall plots that the majority of the patients were going down. So that means the majority of the patients had some shrinkage of tumor. Anyone kind of over this negative 30%, that's considered a response. So you see an overall response of 45%. This is first line. 95% of patients had shrinkage, disease control 90%. And here, this is any line. So patients even who have been previously treated. Here an ORR, overall response of 30 at 92% at tumor shrinkage, disease control of 89%. So, these are numbers that we've never seen before in uveal melanoma and metastatic uveal melanoma. So it's very exciting. So the hope is that this drug will get approved following this trial. I will say, and some of you have heard, and I think it's been shared kind of in the online support groups and whatnot, that even though the first line trial is restricted to A2 positive or A2 negative patients, there may be an opportunity soon for patients who are A2 positive who got tebentafusp to be enrolled not on this trial, but actually on an arm of the original trial that is actually shown here. So more to come on that. So the other thing that I like to consider, when deciding which treatment option first is where the tumors are. So as many of you know, patients with metastatic uveal melanoma, the first place that it likes to go, and often the place that can become life-threatening, is in the liver. But there are patients who have either extrahepatic only or extrahepatic dominant. They may have a couple little liver lesions, but they, have a whole lot of stuff going on in the lung. So that is a decision point. So if they're intrahepatic dominant, you may want to consider liver-directed therapy. You can also consider systemic therapy or even combination. And then extrahepatic dominant, you're probably going to want to choose a systemic therapy. So as I mentioned, I would say more than 90% of the time, liver metastatic burden is really what's dictating survival. Some treatments have restrictions regarding sites of disease. So HP, taste hepatic perfusion, Hepzato, really limits the sites of extrahepatic disease. So you can't really have like a whole lot going on in the lung or a whole lot going on in the bone. You can have some sites that may be amenable to radiation, but not a lot going on. Other liver-directed therapies, we tend to be less stringent. There are trials coming that you need kind of injectable disease. So that'll kind of be a parameter that needs to be considered. Rare to have extrahepatic disease only. Often it can be associated with, lung as the primary site. There's a specific mutation called SF3B1, where sometimes we see in those patients to have lung first, at least. There tends to be kind of a better prognosis overall. And though many patients may start with extrahepatic only, most, if not all, kind of eventually develop liver metastasis, which even if you started with stuff outside the liver, it's still sometimes the liver that becomes what's life-threatening. And then the important thing is that there's a number of trials that are coming out to address groups of patients with combination hepatic and extrahepatic disease. I mean, it's just the reality that that's often what we see, and we need treatments and trials that address that. So just a few slides on PHP and Hepzato. This has been discussed kind of for years. Most recently it was FDA approved almost a year ago now. And then the publication actually just recently came out looking at the efficacy and safety really of just the single arm. So there was kind of 2 arms in the trial, but this is really a publication on the patients who got PHP. So, here on the left lower hand corner is just kind of an illustration of what PHP is. It's a catheter system essentially that kind of closed circuits the liver so that you can perfuse the liver with chemotherapy through the artery. Then the blood kind of goes through the liver, collected in the big vein. But because there's a balloon at the top and the bottom, the blood just kind of goes in the middle, so it doesn't go to the rest of the body. Then that blood is kind of sucked out, put through a filter system, and then put back into the body. And this can be done up to 6 times, typically every 6 to 8 weeks. So here you can just see a snapshot. And again, this publication is now out of how patients did. So there were 7 patients who actually had a complete response, 26% that had partial response, and then another 34% that had some stable disease. You can see duration of response, the 1-year overall survival, 80%, which is pretty impressive here. Overall survival, 2 years, 43%. And so, and then they're specifically hepatic kind of endpoints, so really just looking at the liver. And so with an overall response rate, so kind of percentage of patients in which the tumor did shrink, 36%. And then this is a survival curve of showing patients who had the complete response. Obviously their survival was much better compared to those that even just had a partial response or stable disease, but being better than patients who only had progression. And, while it's not in this current publication, in some of the original presentations that are available, I think, online, this looked better than the patients who were treated in the comparator arm, which was mostly just chemo embolization, but of various kind of types because it was dependent on the location. So, I would say other than HLA in that first break point, and maybe even more so, at least at our institution, kind of overall tumor burden and how quickly things are growing probably weighs the most in how we decide on treatment. Because if you have a patient who has bulky tumors, large tumors that are growing quickly, sometimes you got one chance. And so, you don't want to delay, you don't want to kind of make the wrong first move because that can really affect what happens down the line. So, we often take this parameter very seriously in making recommendations. So if tumors are big or growing quickly, really want to be able to start something quickly. So unlike what Dr. Berry said about the primary eye tumor, where, a delay of a couple months probably not going to change much, here in metastatic uveal melanoma, sometimes tumors can double in a week. And so if we have a couple of time points that are telling us that's how quickly things are growing, you need to start something quickly. And ideally, we would also start something that has a higher response rate, right? If you're starting out with a lot of tumor, you want to be able to shrink that tumor. Whereas if there's limited tumor burden, or you now have a couple of scans where things are growing slowly, because that does also happen, then really all options should be considered. And we should be looking at all the other parameters that I mentioned. And so going back to those 2 kind of cases here, if it's really just a solitary tumor, not even a centimeter, some treatments may actually be reserved. Meaning if it's not quite a centimeter, you may not have a clinical trial. Certainly if they're ALA2 positive, first line tebentafusp for these patients makes sense. There's certain liver-directed therapies that we don't necessarily recommend if there's really just one solitary, 1 centimeter tumor. And then the thing that does sometimes come into play here is if there's really one tumor, and we always kind of make the rule, there needs to be a little bit of time between the eye diagnosis and the scan, because sometimes you just want to make sure it's not like just the tip of the iceberg type thing. And also like to see it at least on a couple of scans that there's really just one. That's when things like ablation can be appropriate. So, and I say ablation almost kind of loosely here now because there's a number of different things you can do. So true kind of microwave radiofrequency ablation. There's other new strategies for kind of targeting solitary lesions. Sometimes just focused radiation if ablation's not able to be done, accessed, that those can all be offered. If the tumors are large and growing quickly, want to start something immediately. Percutaneous hepatic perfusion does have an exclusion for greater than 50% involvement. Clinical trials, while we love clinical trials, there are patients that can't wait a month necessarily. And we have all, us, who do clinical trials in the space have all seen patients that were referred for clinical trial, and the time it kind of takes to kind of get the patient there to do a little bit of the screening, all of a sudden you've lost control of the liver, and that can be an issue. You're, watching liver function very closely in these patients. You can offer debulking with chemoembolization, which is often kind of at our institution what we offer patients with very large tumors who are growing quickly, because that's sometimes our best chance at kind of stopping things until we have a very effective systemic therapy, which, going back to just, bring up the Darrow Crizo story, if these pills really show us that we can shrink tumors in that percent of patients, that may also be a good option for those patients in the future. We know that patients who were on the trial who had bulky disease, so we call M1C disease, which means largest tumor greater than 8 centimeters, those patients did not do well with tebentafusp out of the gate. Ipi-Nivo has, kind of a lower overall response rate than we would like to see. Patients can get that locally. So normally if there's a patient who has a lot of tumors progressing, maybe symptomatic, if they can't get to, an expert center for, something else, sometimes those are the patients we'll recommend just start Ipi-Nivo locally, because normally that can be started within days or a week. Larger liver tumors, those patients can be symptomatic. So we also want to make sure that they're not having nausea or vomiting or pain, and may refer to palliative care for help with management of that. So just a little note, about chemoembolization. Again, we offer that quite a bit for patients with really large tumors who are progressing quickly, and have shown in various publications over the years, patients with, here the darker spots or tumors. This is a before, kind of an after. You don't really see that big guy. It kind of shrunk down here. And here's another one that was treated with something called Debdox, which is a type of chemoembolization, followed by more standard. So this is a big, sorry, my cursor's on the wrong side. There's a big tumor right here. And then this is 15 months later, the tumor shrank kind of significantly there. So this is an option for some of our patients with larger tumors. And I mentioned ablation for kind of solitary tumors, or, I think what we also say is patients who have kind of oligometastatic progression. So they had, 10 tumors and only one was growing. Sometimes we'll also ablate those. And we often, like I said, typically reserve, I think this 3-year mark is probably a little more liberal now. But certainly if a patient, say, just had plaque radiation or nucleation, say 2 months ago, and now they have a solitary lesion, it's normally not a great sign. Normally other lesions are going to pop up soon. But if it's been 2, 3, heck, 5, 7, 10 years, and we're really just seeing one solitary lesion, and then often they're a good potentially ablation candidate. And we looked at a small cohort of those patients here who had oligometastatic, or what we call kind of that rogue lesion. And actually they had a 2-year OS of 76%. So some patients went almost 3 years without needing any other therapy after management of just that one tumor. And here's an example of a patient. So here's this here was ablated. That's what it looks like on what's called diffusion. So it's bright white. Post, you can see it almost looks like it's bigger, but that's actually just the ablation cavity. It's kind of just like a crater. And then you don't see anything active here on diffusion. There, like I mentioned, there's other ablation-like techniques being explored. None yet have a whole lot of data in metastatic uveal melanoma. And then also focused radiation can also be used when lesions can't be easily accessed by other modalities. So pivoting now to clinical trials. I was trying to figure out which graphic really was most appropriate for illustrating all of the layers that we think about when we talk about clinical trials with patients. So, the availability, is there just a trial that exists? What is the inclusion criteria? What is the exclusion criteria? What phase of the trial? Is it a phase 1 trial where we're only going to get one slot every month or two because you need to clear a cohort to find a safe dose, and then they'll only allow 3 more patients on? Is it a phase 3 trial where there's a randomization arm? The trial logistics, the schedule. How frequently do you have to be there? Do you just come in, take your pill, go home, or get your infusion? Are you here for 14 hours? All that kind of stuff. Are there biopsies involved? What are the side effects, and are they in line with, what a patient is willing to experience? And then, really just practically the time to start treatment. If it's an issue of slot allocation, it could be months until a slot becomes available. If slots are available, the time it takes to come in, consent, screen, and then start, at minimum, it's normally about 21, 28 days. So all of these things really need to be considered, when you say, okay, clinical trial. I will say that clinical trial availability in metastatic uveal melanoma ebbs and flows. I think a year or two ago, there was so many trials. It was kind of like hard to pick and lots of trials for all different patients, every stage of the game. We're in a little bit of a lull right now. So at least in the US, as of this week, I think there's only one liver-directed trial that's actually here at Jefferson, and we are about to finish enrollment very soon. When it comes to targeted therapy trials, there's this trial called DYP688, which is open, but slots have been hard to come by. Moffitt actually has probably the most in the way of trials right now with these three trials. One's a radiation trial and two are kind of looking at drugs. This is a drug that's used in breast cancer. This is another drug that's actually approved in cutaneous melanoma combined with other things. This is probably the most important trial right now for the uveal melanoma community. This is the first line Darrow-Crizo trial that I mentioned already. And then there's this other phase 1 study that's open at a few sites. And then for immunotherapy trials, there's a couple of TIL trials. There's a drug called lenvatinib plus pembro. There's a trial looking at something called tumor treating fields. And then there's this other trial of cemiplimab, which is an immunotherapy, and then a kind of a vascular inhibitor also at Moffitt. So, I would say kind of compared to, like I said, a couple years back, there's not a whole heck of a lot that's going on, at least trials that are open even at multiple sites, but more are coming. So the last bit of that kind of, not pie, but the four parameters and then the one in the middle of logistics, I just really want to highlight, because I think sometimes we forget that, while HLA status is important, where the tumors are is important, how quickly things are growing is important, clinical trial availability, if I didn't already say that's important. What's really important is the patient. And, with the field kind of evolving and, like I said, becoming more and more complex with standard of care options, with kind of off-label options, with clinical trial options, you really do need to weigh things like patient priorities, needs, wants, preferences, quality of life concerns. Is the patient still working? So, if a patient's still working, then a clinical trial, and the patient needs to be working, then a clinical trial where they need to be in a different city 3 days a week is not feasible. Distance to getting that treatment, other medical issues, insurance, cost, things that we really don't want to have in the equation. I mean, I hate to even ever have to make a decision based on those things, but sometimes it's just the reality of it. Family, commitment. I put on their vacation because, I've had a couple of patients that, we talked about a clinical trial. And it's like, okay, we're going to start, July 1st. And then you need to be back on day 8, which is the following week. And it's like, oh, actually, like that's the 1 week my family goes on vacation. And we don't ever want to get away in the way of patients being able to spend quality time with their family. So there's times literally where we will shift an entire clinical trial enrollment or postpone something or move something up, to be in line with whether it's vacation or someone's graduation or things. So, these are the logistics things that, I know for me are a lot part of what the conversation is when we're actually choosing treatments, in addition to all of the science and all the other things, because I think it's really important. So I was asked to kind of just mention the comment about monitoring while on treatment. So you're on treatment, how should you be followed? And it really varies depending on the treatment. Clinical trials may scan as frequently as every up to 6 weeks or up to 12 weeks. It may also change depending on how long on the trial. So there's some trials where if you're on for like a year, you may be scanned very frequently that first year, and then it actually extends. Our practice kind of for metastatic patients on the whole is it to scan it about every 8 weeks. And we do CAT scan chest, MRI abdomen, CAT scan pelvis to kind of get the bulk of where uveal melanoma likes to go. But that can vary post radioembolization or PHP, given there's different treatment intervals. It can vary if it's during immune checkpoint inhibition or TEBI induction. It can vary if patients are on a treatment break that may shorten or lengthen the interval. Sometimes we add other imaging modalities, so MRI of the brain, PET scans, sometimes MRIs of different other parts of the body, specifically like the spine or hips or things like that. And then I think one of the take homes is that, if you're starting a new treatment, you really should have scans within a month of starting that new treatment, because it's really important to get the best baseline as things can change quickly. So you would say you were going to start a new treatment tomorrow, being June 22nd, and your last scan was April 4th. While it seems, like a lot of work to get another scan because it was just in April, what if there's been a lot of progression since April? Now you start on treatment tomorrow, you may next get your scan in 2 months, And if there's been progression since the scan in April, you have no idea if that happened between April and when you started treatment, or that the treatment's just not working. So very important for us. We were really kind of strict about that, about having scans within a month of starting the new treatment. And then changing treatment plans of progression. I think this is a discussion best had, with a multidisciplinary expert team, or at least with your oncologist who's communicating with a multidisciplinary team. Sometimes there's rationale for sequencing. So sometimes there is rationale for going from A to B versus A to D. Awareness of trial eligibility. So there's sometimes you need to be exposed to something in order to be eligible. On the opposite, sometimes if you are exposed to something, then you're not eligible. And then liver control should try to be maintained through all of it, because that unfortunately, as I've mentioned, is the thing that can sometimes get out of hand and become life-threatening. So kind of in conclusion, the diagnosis of uveal melanoma primary can be overwhelming, but certainly the diagnosis of metastatic uveal melanoma can be overwhelming for, I say 101, but I'm sure it's more like a gazillion reasons. And I think having connection to a knowledgeable medical oncology team from day one can often expedite diagnosis and treatment. So just as Dr. Berry, was saying, there's a lot that can happen in that first week or two, and it's nice to already be connected. Biopsy should be attempted if tumor is suspected. HLA should have been done during surveillance or immediately once metastatic disease is expected. While there's a number of FDA-approved therapies, access to these can still be a challenge. So whether it's tebentafusp specifically or Hepzato specifically, these are not therapies that are being offered everywhere. So access can still be an issue. And having an understanding of the trial landscape can be helpful if sequencing is needed. And like I said, to avoid things or get exposure to things. And then I really do think it's important to have a treatment plan that considers the logistics. So all the other stuff to work with you to develop an approach that is best for you. And that is it. So as a patient, what can I focus on if I'm stuck in a waiting period, either between scans or treatments, or unable to have a definitive biopsy right away while navigating? This is a tricky one. I say that the limbo between scans, so maybe you haven't had a metastatic uveal melanoma diagnosis yet, but you're high risk. So really the anxiety between scans is real, or there's been a scan that says, there's a little something that we don't like, but it's too small to biopsy. We're going to have to get another scan or something like that. I mean, I think that's probably, and I don't want to speak for patients, for sure, but it's almost worse than kind of having the diagnosis and having a plan, right? Everything's better when you have a plan, and that could just be a very uncomfortable place to be. And it's easy to say, well, just don't think about it. Just go about your life and just do all your things. But that's obviously easier said than done. What I always tell my patients who certainly are in that kind of limbo zone is, listen, we're gonna figure it out. Whether it ends up being something or ends up being nothing, we're gonna figure it out. And, I know that and for some patients, getting data and knowledge is super helpful. So they go to the internet and they research as much as they can, which is fine. But I always try to give patients the comfort in knowing that's also my job, our job, our collective job as, specialists in the field, medical oncologists, across the country and beyond is to know what's going on, right? And to have a plan, when a plan needs to be implemented. So I don't know, that's not really an exact answer to your question, but
it's kind of a nuanced question, I think, for sure.
It's a tricky place to be, but you just have to kind of make sure you're in with the right people and just kind of trust that, they will make the right decisions with you, certainly. There's a question about mental health supports for patients who are navigating a diagnosis, treatment, and care. I mean, I can't speak more highly about the advocacy organizations. So number of advocacy organizations, I know Cure Insight has patient support groups. I know that's not necessarily kind of mental health support, but every cancer center normally has either social work or even kind of psycho-oncology that can help kind of navigate patients more individually, through all of that. If your cancer center does not, even so much as talking to your primary care doctor and getting a referral to, a psychologist or a therapist can be beneficial. So I'll jump to this one. So what are the benefits of spot treatment versus a whole lobe treatment in liver-directed therapy? Any data to support one over the other and how patient presents and tumor burden kinetics, genetic indicators? So I don't know if that means spot treatment, meaning like ablation versus whole lobe. So liver-directed therapy kind of in general, whether it's immunoembolization, chemo, and radiation or PHP, really treats the whole liver, at least in pairs or at the same time. Whereas things like spot treatment, so there'd be ablation, radiation or some of the other kind of local techniques. I think the benefits of spot treatment are sometimes it can just be a one and done. You're giving a lot of treatment to that one area, but it obviously doesn't treat the whole liver. Whereas if there's multiple tumors, then spot treatment's not a good idea and you want to treat the whole liver. There's also some thought that some liver-directed therapies, so certainly even something like HP, where you're really saturating the entire liver, may also be killing cells that you can't see yet radiographically. There's no genetic indicators, though, that really have guided us in liver-directed therapy world yet. All right, so moving on to Leslie's question. I am A negative with no Mets. What is involved in the Daro-Crizo trial? Is it an oral medication or more complex than that? Where is it being conducted? So it's kind of a long question. I said, hopefully you'll just never need any of this information, but it's being conducted at various sites around the world, actually. So lots of sites in the US. It's like I said, it's a randomized trial. So kind of 2/3 of patients get randomized to the Daro-Crizo, which are pills that you take every day. And then the other patients are often randomized to Yervoy and Opdivo, which is an infusion that's every 3 weeks and every 4 weeks. There are some kind of extra little testing that has to happen with doing like EKGs to monitor your heart and blood tests. But certainly anyone who's interested in that trial, I encourage you to speak with a physician who's participating to see if you're eligible and what else goes into it.
Wonderful.
See it look on time.
We've got about 5 minutes.
Yeah. So what are some of the local expert centers in the US with uveal melanoma medical oncology presence? I believe a Current site has that resource somewhere.
It's a little tricky. The physician
Okay.
finder on our website, Dr. Barry referenced, I don't believe that we have a medical uveal melanoma oncology like specifics. I think it mostly focuses on ocular oncology.
Okay,
So I guess
gotcha.
this was more of a question. This is actually from me. Just like, I know we know of Thomas Jefferson.
Yes.
You mentioned Moffitt Cancer Center. And so I'm going to assume those are two kind of regional locations. But if we could, pinpoint maybe an area where of uveal medical oncologist in the Midwest. And then I know my doctor out here in the West. That way we could kind of just show people on the map.
Yeah, I mean, I always appreciate this question. I just also don't ever want to leave anyone out because I think there's
It's so hard.
There's a lot of centers, and I definitely don't want to leave anyone's centers out. But you could probably think of almost any major academic center right now in the U.S. There's obviously the sites in Boston, sites in New York, here in Philly, Baltimore, Atlanta. I'm just literally going down the map in North Carolina and Charlotte. And I'm also really bad at geography, so do not penalize me. A couple of sites down in Florida, Texas, Colorado, Ohio, Arizona, obviously California, Oregon. I mean, there's definitely some states in the Midwest, no, there's not really an expert site in North Dakota or South Dakota, and those patients often have to travel. But, I think this is where going to some of the patient support groups, and you could probably geographically hear about kind of, who's open, or actually just going on clinicaltrials.gov. Honestly, if you were to look to see which sites are offering the Daro-Crizo trial, that's probably a site that sees, uveal melanoma, because then there's some places you don't think of, like University of Iowa. It turns out that, they see quite a bit of uveal melanoma and have this trial. So again, I don't want to leave any sites out because I think there are a lot of sites that see a decent amount of eye melanoma and have a lot of options for patients.
Yeah. And I think, like you said, it's ever changing, ever growing.
Mm-hmm.
And I think it's just important that patients recognize, hopefully, that there is something on the map that they can locate, and it doesn't necessarily have to necessitate them traveling from East Coast to West Coast.
Yeah.
There may be something in between.
Yeah.
Okay, wonderful. Well, do you want to pick one more question? And then I can send you the rest of these via email.
Yes. Let's see here.
There's a liver transplant question. Do you want to cover that one? That's an interesting question.
I can. It's a softball. So no. So liver transplant is not an option for metastatic uveal melanoma. A lot of patients ask that, because if you were to Google liver cancer, liver transplant's an option, because in that case, primary liver cancer, right, the cancer starts in the liver, whereas in uveal melanoma, the cancer travels from the eye to the liver. So it's basically assumed that cells are circulating. So just by transplanting the liver, you're not really going to eradicate cells that are floating around. And then you have to go on immune suppression, which is also not good. And, the cells in theory can just kind of hone their way back to their liver. So
Yeah.
we do not, you can't, that's not an indication in the US for liver transplants.
All right. I think that covers it, unless you see one that you're dying to answer right now.
Yeah, I think that's pretty good. I can answer the
Okay.
other ones offline.
Awesome. Well, I will go ahead and get those answers from you sometime in the next week or so, but please, thank you. Well, thank you so much for being here, for your time, for your expertise. Thank you to our audience for being here. And I will go ahead and dismiss you, Orloff, so you can get to the rest of your Friday afternoon.
Thank you. All right. See everybody.
Bye. All right. Well, if you guys are still here, hang out for just a sec so I can give you some housekeeping announcements and we will wrap it up. So just by way of your information, if you didn't know this, if you didn't come across the registration link for this webinar in a way that you had hoped, please register at our website. You can go to ocular.org, and at the top area of the website, there's a little button that you can push that allows you to register for our newsletter. Our newsletter goes out every final Friday of every single month. And then we also will push out just news releases, press releases. So this is one of the best ways that you can stay in the know on what is going on in the uveal melanoma space right now, this month. What's the new data? What kinds of things should you be aware of with your doctor? So please make sure to subscribe to the newsletter. Head to the website at cureinsight.org, and you can just find that little subscribe to the newsletter at the top area of the page. Our website is also a wealth of information. Dr. Berry mentioned the clinical trial finder, or the physician finder. Dr. Orloff mentioned the clinical trial finder. There are so many resources, and if you have feedback for us and would like to send us that, please send us an email at contact@cureinsight.org. Finally, if you're here, you're listening, you're watching here live on the webinar, thank you again for being here. Go tell a friend to register for the next webinar when you see it. Make sure to help us share those posts on social media. And if you have not already subscribed on the YouTube channel for Cure Insight, or on one of the podcast listening platforms, depending on your listening preference, please make sure to go ahead and subscribe to those platforms so that you can stay up to date whenever we release a new episode or we have a recording that goes up from something like this webinar. By way of just final quick announcements, we have major events coming up in the next few months. Our first event to be aware of is our patient meeting. That is the I Believe patient meeting, the I Believe survivorship seminar. It's going to be hosted here in my hometown in the Scottsdale, Arizona area by Dr. Justin Moser with the Honor Health Research Institute here. And we are thrilled to be here in Scottsdale. We hope you will make the trek. It is in October, and as an Arizona living in the sun, Omi, I can tell you October is when it gets much more pleasant. So we're going to be there mid-October. You can find the details on our website. You can also just reach out directly if you have questions or find our social media posts regarding registration for I Believe. If you're not already aware of our 5Ks happen all around the country, and I believe we have a few coming up the remainder of the summer. We've got one coming up in Palo Alto in July. We've got a Seattle 5K coming up. Later in August, we have other dates happening, and if you head to lookinforacure.org, you can find out if there is a location near you. We would really encourage you, patients, to be there. Caregivers, pharmaceutical companies, representatives, encourage your doctors, your community to be there in person, but also to fundraise for us, because we cannot put on these events without fundraising efforts. We have to be our own advocates in ocular melanoma, and that can be really hard and really draining. And so just finding the ways that we can rely on community support can be huge. We appreciate all of you who have made the trek out to the 5Ks. This year we have some special 5K medals that are going out for just survivors, for ocular melanoma patients specifically. So if you haven't gotten that special medal, please make sure to make your way to a 5K in person. And those are given out to patients during the events. And lastly, if you guys have just a quick minute, sometime this month or at a future point in the year, really, you could do it whenever you choose, anniversaries, your birthday, any other kind of time in the day. If you're on social media in any capacity and you're willing to make or learn how to make a social media fundraiser for us, then we would love it if you would help us fundraise for Cure Insight so that we can continue funding things like these webinars, patient programs, patient financial aid, and of course, funding critical research for ocular melanoma. We can't do this alone. We need your guys' help. We need our patients and our caregivers. We need the community coming together. So thank you for listening to my TED Talk. Thank you for being present for the webinar today with Dr. Berry and Dr. Orloff. And we will see you guys next time. And just stay tuned for the recording of this episode from the webinar series.